Hello and welcome everyone to the Davis Phinney Foundation's Live Well Today webinar series. My name is Melanie Dizon. I'm the Director of Education and Content at the Davis Phinney Foundation. And I'm really excited to be here today with Dr. K to talk about Parkinson's disease psychosis. Dr. K, first of all, let's talk pink. We both got on the thing and I was like, oh, we're matching. This is great. So Dr. K, can you share why you're wearing pink today?
Well, I promised my daughter, it's cancer awareness, breast cancer awareness, and so she races. She's 10 years old, and she does bake sales quite a bit. And I promised her I would wear pink for a whole week if she raises like $500 or more. And she raised about $600 for the Susan B. Komen breast cancer awareness program. And there was a walk and everything, and so. This is my last day of wearing pink. So I've been wearing different hues of pink all through this whole week.
Well, this hue is perfect because we're matching. I love it. Okay, so let's get started. So you're currently a practicing movement disorder specialist at the Minder Center for Movement Disorders in Oklahoma City. And I did share your full bio, but I'd love to have you tell us a little bit about how you became interested in this field of work and working with people with Parkinson's, and then specifically your work related to Parkinson's disease psychosis.
So for neurology as a whole, I think it's always been ingrained in me that I was going to be a physician, but I've had a couple of relatives who've had really severe neurological disorders. Some of them very devastating to the point they were pretty much just in a chair, day in, day out, spastic, stiff, could barely speak. And it always irked me to think, why is it that we can't do more for this person? There must be something which you could do. So much so that this poor person who was extremely intelligent and, could not communicate effectively, could not get a lot of things done by himself and required help for all bodily functions. And so that's where I started to think like, maybe this is where I need to focus as a physician and get into. And of course, through medical school, we see tons of great professors. They help mold you essentially and make you sort of gravitate towards their field of sorts because they're great teachers. And I've had several great neurologists, professors who helped kind of shape me. Movement disorders per se for almost the same reason, because Parkinson's is one of those disorders where you could get into that sort of scenario, which I just described about my own relative. But if we intervene early and strategically, we can keep people functioning for very long stretches because it is a long disease. If appropriate intervention is done, and I always like to use an analogy of cars and gasoline, and it's like you don't wait for a car to break down to do an oil change. And it's that same principle. A lot of these things are preventive management. And I think Parkinson's really fits in that mold. And so for me, movement disorders was a natural extension of what all I could offer for a patient. There's a lot of interventions that we can do in Parkinson's, like a lot of the patients who are on today, and you yourself know this, like we have deep brain stimulators, we have pumps, we have injections, we have Botox and other related injections that we can do. So many things that we can offer at every juncture. Like there's something going on, there's always something I can pull out of my hat and go, okay, let's try this. There's never a scenario where we go, that's it. That's all you can do and you're going to live like this. So there's always hope. And so I wanted to be in a field where I could really offer a lot of different options for patients.
It's great. Yeah. And I think, it's probably satisfying, right? To have somebody come in and, they're not living well. They're maybe not taking advantage of the different medications, different surgeries, or even, non-pharmacological things like exercise and drinking water and doing all of those things. And they can come in and you can say, hey, let's try this and this. And then you see
it is. It's very much so. But it's also, again, it is a process, right? So when we explain a lot of these things, it's a lot of information many times for patients to digest in one go. Like our new visits with our patients, we go over every element, including medicines, exercise, psychosis, bowel movements, you name it. But it can be very overwhelming for patients. So many times we sort of jot down and give them a full copy of our notes, which we do for every patient, every visit, they get full copies of our notes. And we also put in a quick blurb and a line with links to free books, like the Davis Finney has a great manual. And we say, look, you're going to have a lot of questions, or you may have this one issue which we talked about and you didn't have, but it may happen between our next visit and you start to develop constipation. He mentioned it. What do I do about it? There's like 3 pages worth of stuff in this book. So we would leave things like that too, so that there's a lot of reading, education. And I think Parkinson's patients are great about that. Some fields within the scope of neurology, these patients, just because of the way they get the injury to their brain, they're very resistant to either accepting new therapies, learning about new things. And it's just because of the damage they accrue in their brain, they just become like that. Parkinson's, we always have seen they're very motivated. For the most part, you don't get the unmotivated patients. And there are always some like that, but for the most part, they're always eager to like, what's this next tweak that I can do to my day to make things better?
Right. Yeah. I think I probably get emails every day from people that are in the community and say, hey, have you seen this? Have you seen this? Like I love it. They're just very much into the research, want to learn everything they can, want to share it with everyone they know. And that only helps the community. So I'm sorry, if you hear an echo, let me know. I think Parkinson's disease psychosis is definitely one of those things that probably comes up in between appointments. It's something, especially when people are initially diagnosed, they're not thinking about this. And I know that many people that come to us say, my doctor never told me. It scared them so much because they hadn't had any information about it. So first of all, can we, especially for the people who weren't able to see the first one, can we define what Parkinson's disease psychosis is? And then can you talk about sort of the 3 main elements of it?
Fair enough. So for people who are relatively new to the Parkinson's space, they make the assumption that Parkinson's is a very physical disease. Like, hey, I'm going to start to get slow, or I might get stiff, my tremors are going to get worse, or I might start to shuffle because I've seen that one person, or my grandpa had this, or I've seen this TV personality have it. And we're assuming this is a very physical disease. The funny thing about this disease is that it spreads. Many times it has to hit these non-physical circuits first before it gets to the physical circuit, and vice versa too. And eventually, as the disease spreads, it blooms out in your brain to all these different little sections of your brain. One such section, which is almost shared space with your Parkinson's circuit, is your mood and hallucination circuits. So it's one of the first things that the disease creeps into is your mood circuits and your hallucination circuits. So this is why people find it odd sometimes, like, I thought this was a physical disease. Why am I feeling depressed or anxious? So just to get a baseline is that a lot of non-physical aspects will occur in a Parkinson's patient. It's just pure random as to how it spreads in your brain. So one person may have more of mood issues. Another person may have more of blood pressure issues. Another person may have psychosis. It's very random. And so if you had to define psychosis in Parkinson's disease, it's basically 2 major things which happen, which is either hallucinations and or delusions. So what is a hallucination? Hallucination is your brain cooks up information about something that you sensed when there was never such a sensation to begin with. For example, your brain cooks up a sensation that you saw something. There was nothing in the environment for you to have perceived that, but it cooks it up. This is, in plain speak, a hallucination. So hallucinations is with all your 5 senses. So seeing, hearing, touch, smell, taste, it can be any of them. But in Parkinson's, predominantly, it tends to be a very visual form of hallucinations. And we'll go in more detail as to the flavor of those visual hallucinations. What is a delusion? A delusion is a false, fixed, usually very irrational belief which the patient cannot shake despite being given evidence to the contrary. So you can tell them 100 times, you can show them all the evidence saying this is not true, but you are still stuck with that notion. No, I know it's true. And so there are various flavors of delusions too, which we can break out in detail. So these are the two major criteria to define psychosis in Parkinson's disease. However, most people with Parkinson's disease don't start off with these symptoms. They start off with more subtle, or what we call minor phenomena. These are major two phenomena, which is the hallucinations and delusions. The minor phenomena include, one, illusions. Illusion is a false perception of something which actually happened in your environment or on you. So for example, I see something with a flickering of the lights, and you look very quickly to the side and you go, was that lightning outside that I saw? No, probably that was my light bulb. So you see something, but you misperceive it. That's an illusion. So for example, like what magicians do, they play tricks on you, which is your eyes play tricks on you with what they do. That is an illusion. So for example, you're sitting there watching TV, you know, a rolled up sock falls from your laundry hamper and it's on the floor. And you very quickly look, oh, is that a mouse? No, wait, that's a sock. So you don't see, you assume it's a mouse because in the corner of your vision, it almost appears like one. When you look carefully at it, oh, it's a sock. It doesn't stay as a mouse. So that's an illusion. And so those are many times early in the game. Along with this, another phenomenon which is extremely common, which we catch many times very early, as long as we ask the question, is the vague, fleeting shadow-like movements, or what we call passage phenomenon, whereby, let's say again, it usually happens in the evening when there's more dim lighting. You're watching TV or something. Right at the edge of your vision, there's vague shadow-like movements, either hovering right there or something dots by real quick along the side or under you, and you're like, huh? Did somebody just walk by? Did the dog just run across? Did a car drive by my window? Now here, there was no actual phenomenon happening in the environment. It's not an illusion. It's a false, cooked up sensation in your brain, but it's the earliest form of visual hallucinations. It's what we call a vague shadow-like movement, a fleeting shadow-like movement. So this is another extremely common phenomenon. Another minor phenomenon which tends to happen is the feeling that there is somebody next to you. So you're sitting there again, reading a book, watching TV. You get this feeling like, is my wife behind me? No. So you keep feeling like there's somebody next to you. And this can expand. The radius of this can expand over time. Like initially it is just next to you. Then it's somebody in the same room. Then you feel it's in the closet. Then you feel like there's somebody downstairs. Then it's somebody out in the backyard. Honey, go check. I think the kids are out there. No, there's nobody there. So that expands over time. But in the initial stages is that feeling. We all get this when we're real tired. Like I'm at the end of my shift, at the end of the day, I kind of get the sinking feeling. My nurse has come with one more thing to sign and I look and turn, there's nobody there. We all feel this.
Right.
Same thing, just happens more and more frequently. The problem with such minor phenomena is that most people chalk it off, oh, that's just my thick rim. I'm just catching the edges of it. Oh, that's my cataracts. That's my glaucoma. They poo-poo it off as something else. And this goes underdiagnosed for years. So this sort of minor phenomenon will occur for 2, 3, 4 years before you bloom out to the real deal stuff. So in hindsight, when we ask patients this, and they come in complaining like he's seeing stuff, and we ask about this, they go, oh, that I've been doing for about 5 years. Ah, and so this is why we always make it a point, especially in movement disorder centers, we will ask this question as part of screener and as part of our regular follow-ups is sort of a tick box that we ask, the fleeting shadows. It always almost gives us the most mileage in terms of one question if I had to ask.
Oh, wow. That's interesting. I've never heard that before. Is anybody watching have any experience with these early signs that you want to share, if anything is resonating for you? And then also, so these might occur over a course of 3 to 5 years, maybe, obviously depending on the person, but it's not unusual for them to go on that long. And then can you talk about the different flavors that you said of hallucinations and delusions?
Definitely. So starting off with hallucinations, let's start with visual hallucinations. So the earliest bit of that is what we just talked about, the shadow-like flickering movements along the edge or darting by. Eventually, it becomes more well-formed to where it's not just a shadow. It's almost like a figure, like it's a person or a kid or an animal, and it's there or it's moving, and you can catch almost like a full-fledged image. If there's no color to it, it's shadow-like. Then eventually it becomes fixed and within your full vision space, not just at the edges. This is how it usually evolves. And more often than not, it tends to be in the latter half of the day when your brain is tired. The more tired you are, the more your brain is susceptible to these sort of hallucinations. This is why a lot of people see it in the late night or in the middle of the night. They wake up from their nap or their sleep, and they look in the dark, in the shadow, they see a brief image form and it goes. So they very quickly, they get scared because they think somebody's standing there next to them while they're sleeping or in the corner there. So you can see how this can be very disconcerting to people, especially if your loved one with Parkinson's is in a facility, is in a nursing home setting. What happens? Next day when you talk to them, they're saying, somebody was standing in my room. Oh, it could have been the AIDS. And then every day it happens. So then it starts to get concerning, like, and you start calling people going, who's in my dad's room? And so this is how many times it evolves, and we still think there is no hallucinations going on. He's waking up and seeing somebody there. So this is how it starts to happen. A lot of people are extremely predisposed to seeing small objects, either inanimate objects or small things like animals, babies, kids kind of just walking around too. So these are all things which slowly start to evolve over time. It never is extremely bizarre or morbid. And it's not extremely developed hallucinations. It's usually very static, like there's a person is standing there or maybe barely walking, and conversing to them or anything doesn't usually, you don't get a big interaction there. Hallucinations can take on also a minor flavor, like lines on the floor, on the wall, and all of them will start to merge and separate out and merge back in. They undulate and they go in waves. You can see sometimes creepy crawlies along the floor, like bugs and stuff, or the bugs start to come on you. So that you're constantly seeing them touch and move things when there's nothing there. Or did you tidy up the space? There's a lot of bugs in my room. So these are all the usual things which start to happen from a visual perspective. Number 2, hearing. So auditory hallucinations, again, tend to be very subtle. The classic psychosis that we think about where people hear things is schizophrenia. But it's much more developed forms of hallucinations where they hear commands, people having conversations. This is not how it happens in Parkinson's. In Parkinson's, it's more subtle. Vaguely, they feel like there's music being played in the background. Or somebody calls out their name and like, huh, did you call me? No. So they think it's a hearing issue. They're not assuming there's auditory hallucinations. Vaguely, they hear bugs or birds chirping. These are the usual phenomenon which happens with auditory hallucinations. tactile or skin-based hallucinations. As I said before, people feel bugs creepy crawly on them, lint, like they feel like hair, the hair's fallen onto their skin and they're pulling out stuff. Sometimes this gets very, very severe, this concept of having bugs on them. So they're constantly feeling like there's lice, there's ticks, and they will bring things in their old pill bottles many times saying, Doc, I know my wife is half blind, so she can't see, but you see it, right? You see the bugs in here, and all I see is some lint and dead skin. So it can get very severe for some, the tactile hallucinations, usually bugs. But another flavor of tactile hallucinations is people grabbing at their legs or their arms. So this happens in the middle of the night. So they're sleeping, let's say you feel something crawl up the bed under the sheets and you think, oh shoot, I live in a farm, is it a snake? Or somebody yanks the leg, or somebody's crawling in the bed. You get a feeling like that and you look, there's nobody there. Again, you can see how this is going to go real wrong if the person was in a facility. And next day on the phone to the daughter, she says, somebody was kind of messing around with my legs yesterday when I was sleeping. And then everybody's calling and trying to figure out what happened, who was there. So many times it's stuff like this. So that was tactile hallucinations. So then you can get also olfactory, sense of smell. And so sense of smell hallucinations, it's again, remember Parkinson's patients lose their sense of smell for the most part. And especially when they go years with this, they've definitely lost their sense of smell. And all of a sudden now they start saying, hey, did you burn something? And it's almost always at the same time in the evening. Did you burn something? It seems like I smell smoke. Or they're always looking for that dead rat in the closet. Like, what are you up to? There's something smelly here. And it's always at night that he's trying to figure it out. Why? Because it's that time when the hallucinations pick up. So these are all the different flavors of hallucinations. What about delusions? Delusion, as I said, is a false, fixed, usually irrational belief. So the most common one is paranoid delusions. People are just paranoid. They're upset, they're worried that people are ganging up or plotting things around them, usually to your detriment. That's how they think. It's like, why are you telling Dr. K all these things? You know, I know what you're up to. You want to throw me in a nursing home, right? So that's how they think. So that tension is there. And we see it sometimes in our clinics, that you have the patient sitting there and you have extremely uncomfortable family members all kind of keeping quiet and kind of darting their eyes and looking at each other, nobody's saying anything. And anytime I ask a question, the patient's like making sure that they better not say anything. And that's when you know there's some tension going on in the background, that there is this conflict is been going on for a while. So this can happen with their own kids. It can be with your aides. Those guys are always stealing stuff from my house, or I don't want to be left alone with them because I know they're up to something. The neighbor's up to something. Why is he turning his dish antenna this way? There's nobody there. The house is empty. No, there's something there. And they're always stuck on that notion despite giving evidence to the opposite. The second kind is delusions of infidelity or jealousy. So they're jealous that their spouse, probably married to them for 40 years, is cheating on them. Or sometimes is delusions where they feel like their kid or somebody close to them is cheating. And they come in talking to me about, Doc, I'm so upset. I thought I raised my son better than this, but I said, what's wrong? He's been cheating on his wife and it's no good. And so, on the next visit, I remember and I asked, and at that time happens to be that his wife is there with him, and she goes, no, none of that stuff actually happens. What are you talking about? And that's when I realized, oh shoot, he was having a delusion, because it seems very plausible to me.
Right.
So these things so those are all variations. And finally, there's a third kind of delusion, which is not terribly common, but it can happen, is delusions of reference where they infer themselves into situations which have no bearing to them. Like, let's say he's watching the evening news, and very quickly he jumps and says, I told Joe that that wouldn't work, that we shouldn't pass that. What are you talking about? Who's Joe? Joe Biden. Huh? That bill would not be passed. I told him. And so somehow they interject themselves into the situation which has no bearing to them. Those are less often, but it happens too. So these are the two subcategories within this space, of which predominantly it tends to be very visual.
Okay. Gosh, I wish that I could talk to you for 4 hours about all of this. There's so many, so much great information and lots of great questions coming in. A couple I want to address immediately because I got a lot of them via email, and then people are talking about them here. But can you talk about the relationship between hallucinations and Lewy body dementia? And if people are getting hallucinations, does it mean they have LBD? This is a common question we get. Like, what's that relationship?
The Lewy body dementia is a subtype of Parkinsonism whereby you get something very similar to Parkinson's disease. You have the slowness, stiffness, tremor even, but at the same time, in parallel, you're also getting cognitive decline from the very beginning itself. You're having cognitive decline, thinking issues. Along with it, the classic nature of that thinking issue is they have inattentiveness, forgetfulness, difficulty with directions, and they hallucinate. But this is from the very beginning. They're having a little bit of tremor in 2020. At the same time, he started to have thinking issues. By 2021, the tremor is worse and he's starting to hallucinate. Okay, that's the story. Parkinson's.
So the big deal for that is timing.
Is timing, that the history reveals the diagnosis almost always, whereby you're having a very similar form of Parkinson's-like movement problems, along with simultaneous cognitive decline and hallucinations. Parkinson's patients too can get cognitive decline and dementia, but in the lag end of that disease, we're talking 10, 15 years into that disease, they start to get cognitive issues and in turn hallucinations then too. And which means what? The same story is given by the Parkinson's patient who's brought in, he's coming in with his walker, both sides are affected, he's pretty obviously affected physically, and he says, Doc, last 6 months, my thinking is not good. I'm having difficulty with directions. I've been starting to see things. That's the story for Parkinson's patient. So Parkinson's disease patients, that's the guy who comes in and tells me this same story for the other person who barely has any physical symptoms and says the exact same thing about his thinking and hallucinations from the get-go. That's the difference. So just because a Parkinson's patient gets hallucinations down the road doesn't mean he is converted to Lewy body dementia. It's a separate disease.
Okay.
Parkinson's disease patients, the odds of getting hallucinations is about 50% in their lifetime with Parkinson's. So with Parkinson's, you can get hallucinations early in the game, middle of the game, or towards the end as well. More often than not, it is in the middle and the end. Middle, where naturally as part of your disease spreading or blooming in your brain, it hits the hallucination circuits. Towards the end, eventually when it starts to hit the thinking part of your brain and you start to get a cognitive decline or dementia with Parkinson's, the natural characteristic of that dementia is also hallucination. So that's another scenario. In the early stages where Parkinson's can get hallucinations, it's usually drug-induced. Like you give them a certain drug and it tends to kickstart hallucinations temporarily. That's the early scenario where Parkinson's patients can get a drug-induced phenomenon of hallucinations.
Great. So that is a super important part because I think that there may be people on here that had an early diagnosis and then had early hallucinations and they're thinking they have Lewy body when it was really a drug-induced situation, which is a totally different situation, right? When if it's drug-induced, yeah. Okay. That's great.
Correctable, and their cognitive issues do not last because let's say the offending medicine is also pulled out, and on the formalized testing, which we call a neuropsychological testing, they do great on the testing. They don't show a decline or perform in the performance of all those testings.
Okay, that's great. What about people who are, young onset diagnosed? What happens to be there is the same progression usually as somebody who's diagnosed later in life when it comes to hallucinations?
So people who are much older when they develop Parkinson's, they already have a little bit of baseline cognitive decline just from aging. Just 75, my brain's not going to be as healthy as somebody in their 40s. So there's already a little bit of cognitive lapse naturally as part of aging. Those folks tend to be more predisposed towards an earlier onset of hallucinations because, as I said, when your brain's fatigued, that's when it plays tricks on you. Just because of age, your brain's a little behind on the game. And on top of it, you add Parkinson's and some of the medications which are potent, they tend to get more predisposed towards hallucinations. There are certain subtypes within the Parkinson's disease. Again, this is more academic than really for patients, where we go and talk about tremor predominant Parkinson's or akinetic rigid forms of Parkinson's and so on and so forth. Within that, there are certain subtypes we know tend to gravitate towards cognitive and hallucinations earlier than the remainder Parkinson's disease patients. We don't call them Lewy body dementia. It's just Parkinson's disease blooming into Parkinson's disease, dementia, and psychosis earlier.
Okay. Just a couple of comments. A lot of people have said I have early illusions, especially in a darkened room. My husband sees rows of ants in rows on the floor. At one point, this person had the husband take a picture of it, and he was like, "See, you can see them now," and she couldn't see them. A lot of times I'll hear small chatter, like talking or a TV is on. It seems to be like one side of the ear. I don't know. Is that common for it to be just coming?
So that's an important point. Remember, as I said, with the brain, the more damaged the brain is, the more susceptible or more fatigued the brain is. It's the same goes with your sensing organs as well. So if you tend to have cataracts, glaucoma, your vision itself is impaired, you're more predisposed to some of those illusions and hallucinations more. Same way it goes with hearing issues too. If you tend to be deaf on one side more than the other, these sort of things tend to factor into body parts which are more damaged. You have neuropathy in your hands and feet, you're more apt to feel things on you.
Okay. So let's say somebody is starting to experience this. Is the expectation for sure that they're just going to get worse? Or is there anything people can do to stop the progression of them?
So let's assume that the hallucinations which are happening currently, let's say it's just vague shadows, or they get a feeling like there's a person next to them. And we've chalked it off to that it has happened more than a couple of times, and it's happened at least for a month or more, which means it's gone past the point of something being secondary to, let's say, a UTI, an infection, dehydration. These are all these extra things which can incite hallucinations temporarily. So we know it's not any of that. As long as we've excluded all of that and we've excluded medications as being a possibility, we just keep tabs on them and we tell them, make sure you keep tabs on these things because this can bloom out as the months or years go by. Especially during summer months, make sure you stay hydrated because that can amplify the process. Or come COVID season, you're going to get a bronchitis, again, an infection is going to amplify it. So they tend to stay slow progression, slowly over the course of, I would say, 2-3 years, even slowly picking up. But there's going to be these disruptions, which is completely unpredictable. We can't predict when is the next time you're going to get the bronchitis. But we can help offset it quite a bit if you keep practicing your speech therapy and making sure you don't have swallowing issues. That's why some of these extra things we keep harping on, it's for this reason, is that make sure we don't get the infection if we can avoid it, because my throat is stronger, I'm not aspirating my saliva into my lungs. Those are the kind of measures we take. So we tell them ahead of time, you're more risky for hallucinations. So I need to know, not in the next visit, before that, I need a call saying, I'm trying to see more of that stuff you're telling me about so that I can nip it in the bud with certain medications before it blooms out and becomes bad. Because the FDA approved medicine that we have for psychosis, which is Nuplacid, doesn't kick in immediately. It can take anywhere from 2 to 6 weeks to kick in and fully change the chemistry in your brain, which means what? If you wait till the lag end and it's now really bad, you're seeing things, you're paranoid about your spouse, at that time, if I give you something like this, it's going to take another 6 weeks to kick in. So which would require what? Many times hospitalizing you for the hallucinations. And that many times we do not want. We do not want hospitalizations if at all we can avoid them, because anytime you get put in a bed, not moving, you will decondition in days your muscles.
Right.
And you will come out looking worse off physically. So to avoid such scenarios, we like to preemptively nip it in the bud. When it's starting to bloom up, we correct it with many times medicines which are made for this condition.
Okay, so let's go to the medication piece. So we talked a little bit earlier how sometimes it can be medication induced. Are there certain types of medication that make it more prone to get hallucinations? And then if they are in that situation, they're on medication, but they're starting to feel it and you want to give them Nuplacid, how does that work? Is there anything they shouldn't be on if they take Nuplacid, and what is the success rate? Like, what are you seeing in your clinic?
So first off, in terms of medicines within the Parkinson space, which can amplify hallucinations, all dopamine-based medications have a potential for amplifying hallucinations. But within that, the ones which are probably the highest culprits are drugs like amantadine and its derivatives. They tend to predispose patients much quicker. The second tier tends to be dopamine agonists. These are drugs like ropinirole, pramipexole, rotigotine, all of those guys. And then, of course, we have levodopa. And so many times we will back off some of these drugs first to see if the hallucinations disappear, or strategically change your levodopa dose for less in the evening, because that's when you're seeing this stuff. So daytime, you're great. By evening, you're starting to see stuff. We back off that evening dose a bit of your levodopa. Sure, you'll be a little bit more slower, but you'll be more lucid. So there are those sort of small tweaks we can do early in the game. There are medications which is not within the Parkinson space, which can still impact you, like opioids, right? You get a dental procedure and they're giving you a dentist, trying to do the right thing, gives you pain meds, and it messes with your hallucinations and perks it up. There are medicines which are what we call anticholinergic medications. These are medicines, and multiple different classes of medicines will have that property, including good old Benadryl. So you're having problems sleeping and you decide to take a Tylenol PM. Anything which ends with PM has Benadryl in it. And Benadryl will knock you out, but next day, because of its anticholinergic effect, you're more goofy, confused, and you can hallucinate. So many drugs have that potential. A lot of antidepressants can do that. Antihistamines can do that, of which one is Benadryl. So we make sure those sort of meds are out of the equation, if at all possible. Then we get into treatment options. So one such, as we mentioned, was Nuplacid. And so when we give Nuplacid, we do want to make sure that because all antipsychotics can enhance a certain form of arrhythmia, which is abnormal rhythm in your heart. We will always want to double check and make sure that you don't have that specific form. It's a rare thing, but if you don't have that specific form of arrhythmia, so we'll ask questions regarding that. Or if you already have an EKG in the system or in the chart, we can easily look and pull up and see if you factor in from that perspective. So that's the big thing when we look at from Nuplacid standpoint. And we start, it's a simple dose. It's a once a day dose of 34 milligrams. Any time of the day, with or without food. And as I said, it just takes time to build in. In the trials, 1 in 14 people had complete resolution of symptoms, but the majority of patients, what we saw was a reduction in either the intensity of what you see or hallucinate, or the frequency, meaning how often it happens. And some people got a mishmash of both, like it reduced the intensity some, and also how often it happened, the frequency also dropped. But 1 in 14 will get a complete, it just knocks it out. There's nothing there. What we've seen anecdotally, I can tell you that the earlier you treat this, it shaves it off much better. When it gets to the stage when you're having delusions, like that false belief, it will drop it down, but not shake out the complete delusion. You will still have some. And at that juncture, that's usually very advanced psychosis. We do add other antipsychotics. I know all the other antipsychotics are off-label, but we can add some just to give us extra control along with the nucleic acid.
Okay. Okay, so between medications and some lifestyle choices, we talked a little bit about things that people can do to minimize their hallucinations. Hydration is important, making sure there's no other infection involved, making sure your medications are right, that your timing is right. We talked a little bit, although we didn't talk about the actual thing to do, but the shadows and the time of day and the lighting can be a big thing. So a lot of times you just can turn the lights on. If you're a care partner, you can, if they're in a room that has a lot of shadows, you can make the light brighter so you get rid of those shadows and stuff like that. And I think that would be, for people who have, someone said people who have hallucinations during the day, they could be, maybe some of these other things are at play that are making it happen earlier in the day and lasting the whole day, I'm guessing.
So hallucinations all across through the day tells us that, it has progressed. It has got to a point where if the person is able to get these false perceptions throughout, then it has progressed to where we do need to tackle it, whatever way that is, either take away some of the offending medicines and or adding a specific medicine to suppress it. For the earlier scenarios where they're starting to see it just in the evenings or in the dark, these sort of things like keeping automated lights in your hallway or in your closet so that the minute you get up or move into the hallway, the lights come on. And so there's never a fear of there's somebody standing there as you're trying to get to the bathroom in the middle of the night and then reflexively turn because you thought somebody was there and have a fall. So those kind of things definitely makes quite a bit of a difference. The lighting especially so.
Okay. You said something about insight, and we definitely talked about this last time, where if you're having a hallucination, but you kind of know you're having an hallucination, that means you have some insight.
Mm-hmm.
If you don't know it, and even looking back upon it, you don't recognize that it has a hallucination, that means you didn't have the insight. So I'm curious, and you talked a little bit about being in the clinic with family members. What does somebody do, and what do you do when you're in the presence of the person with Parkinson's who had the hallucination and the care partner, and they don't know how to deal with it? The care partner doesn't know what to say. They don't know, do they go along with it? What do they do?
So first off, insight is almost always preserved initially, and it's slowly lost over time. And what happens is, because we don't catch the initial phase because it's sort of blind, nobody knew about it, nobody was keeping tabs on it. People only keep their milestone of when their hallucination started. When did your hallucination start? Oh, it was last year. And what did you see then? These people. But it happened way before he saw people. Nobody recognized that. But by the time he's starting to see such detailed hallucinations, insight many times could be lost. But almost always it's preserved. So where if we tell them ahead of time, or we tell them, look, those shadows, keep tabs on them. They tell you proactively, I still see them. I'm not bothered by it anymore now that you told me what it was. Sometimes occasionally I get a vague feeling like there's bugs creepy crawly. I don't stare at them anymore because I know it's not real. That's insight. But even with insight, it can get irksome after a while because it almost feels like a person, and it's like you have to look. So it's intrusive. Even though you have insight, it's intrusive to where you have to pause and confirm. No. Okay. and go back to what you were doing. And so even if you have insight and it's intrusive, we still treat it. Now, if you have family members who blissfully ignorant of that this is a hallucination and they're having it every day, let's say, usually their most lucid moments are early morning. If at all possible, if that is there, if there's such a scenario is there, we usually tell our family members and the patients like, hey, you guys are going to do like a quick sit down check, like when you're starting to have your breakfast. Every day you're going to go through this. All right, honey. All right, like we talked about with Dr. K, or like we talked about yesterday, we're going to run through a day. And if you start to see those same things like you do, I know you never remember them, but if you start to see kids or people, you're going to take my word for it that it's not there. If you're not feeling comfortable, call and I will check. And if I say it's not there, we're going to agree that it's not there. And sort of reaffirming the same storyline every day that this is what our plan is, this is what we're going to do. It's not always successful, but there's some element of that programming sticks later on to where, okay, I trust you, it's not there. So they're able to kind of get past that very intense hallucinations, because I kind of remember discussing and agreeing to this, that I'm going to listen to her. So this is one approach. The second thing, do you go along with the hallucinations in the sense that we tell them, look, it is not there. I look, it's not there. You're done. But we never encourage hallucinations. Right? I had patients come in and say, I don't really care too much about my mom's hallucinations because she thinks she sees angels. I said, she sees angels now. Next month, it's going to be something else. And then don't come back to me and say, we should have treated this before. So no hallucination is a good hallucination. And so we always have to tackle them in some manner. Nothing's benign about these things. And so we try not to reinforce the hallucinations by saying, yes, let's put a cream for the bugs on your skin. Yes, let's go see a dermatologist for the bugs. There is no bugs on your skin, but let's go check. Let's get a second opinion. And I say this, I'm not making this up. These are actually live cases of where this has actually happened. And they go again and again, just enabling the delusion when all parties know it's not real. And even asking me for a third referral to make sure it is not there. And so I tell folks like we should not, because that sort of drives it into their mind that it is a fixed phenomenon, and it prevents them from seeking appropriate care. They will refuse active treatment, let's say like with Nuplacid, because they are assuming this is real. No, I want to see the dermatologist. That third guy, I'm sure he will catch it. I don't want to start the Nuplacid.
Right.
The final thing which I tell them is, look, guys, because I've done this long enough, your story is not unique. It is the same old stuff I've heard all along. And while what you say or do could be potentially plausible, I don't think they're your neighbors working in your backyard and messing with you. I think this is what it is. And if you give me an opportunity, we can tweak your medicine, and within a couple of weeks, you will see that it's different. And it does. And we get that buy-in. Give me a couple of weeks, and I will show you that it is different, that this was not really there. Right. And so especially for family members who are jealous, who are suspecting, wanting a divorce, who's paying for private detectives to keep an eye on the other guy. So these sort of things I tell them, look, this is, while it's possible he's cheating on you, let me try this. Because this is a better alternative for all parties. Like if it turned out to be not real, it's best for you and best for everybody.
Right.
So give me that opportunity. So we get that buy-in like that.
Yeah. I want to go back to that cheating piece real quick, but curious about people using CBD for like pain and sleep and all of those different things as dealing with Parkinson's. Has this been known to also?
Yes, very much so.
Okay.
Very much so. So CBD, especially in certain states, including Oklahoma, has medical marijuana is legalized. And so a lot of people use it for sleep, for anxiety control. Sometimes when they have a lot of tremor and the anxiety makes it worse, they use it and it helps. For pain, it helps. And so it's not a bad choice, except the problem with CBD is that this is not regulated in terms of manufacturing. There is no FDA regulation on how this is done, how this is synthesized, what is the exact milligram. It's just up in the air as to who cooks and makes this batch and is sold in the dispensary. And so what happens is, one, you can get a blend of other chemicals in it, like potent psychoactive chemicals like THC, which can make people paranoid and even activate hallucinations. And so if you take something which is even a bit of a blend and it provokes that, the second problem to that is, if it does something wrong, it's going to stick in your system for very long, because it's CBD, THC, all these things clear very poorly from our system. This is why we're still able to trace cannabis use up to 3 months in an individual, because it sits in you. So the same gummy which worked for you this Monday, you keep taking it all the way till next Monday. Next Monday, you take the same gummy, it's not going to be the same effect. All the previous doses is still kind of in your system, and they're going to piggyback along with what you took. So you've got to be extremely judicious with using CBD for any of these things, because you can many times tip yourself too much and you can get real drowsy or apathetic. These are the most common problems we've seen happen, but it can activate psychosis too. In fact, we had a patient 2 days ago who decided, and again, rightfully they tried it, because patient, anytime when they get anxious, they would give him CBD, calms down, goes to sleep. This person had a combination of meds which made him extremely dyskinetic and a little manic. Remember, levodopa can make you manic. And so they said, okay, let's calm him down with some CBD. And they gave him the CBD and he gets paranoid and wants to call the police or Dr. K. There's only 2 people he will talk to, because he's paranoid that everybody else is lying to him or doing something. And he knows, in between, he knows that's not real, that's not real. But then he again goes back. So you can very quickly tip over people with CBD, especially if they're having hallucinations. We tell them, do not do this drug.
Yeah, that's such good advice. And then also, it's not even, some people will say, you can have one bottle and then you buy the same bottle and it's totally different, but it's even pill to pill, right? Like it's in the same bottle, one pill, nothing, next pill, you're completely, it's like you've taken 10 doses, right? And that's the scary part about the lack of regulation, right?
That's right. I mean, and they're cooking batches from something which is sourced from a plant. And so it's like picking an apple and going, wow, this is so sweet. All the other 10 apples on the tree is going to be the exact same thing. No, every flower bud is going to have different components or percentages to this. And whatever you cook from this, a little bit of gummies came from those flower buds, a little bit of gummies came from this one, all from the same plant. It's going to still look different.
Right. Great. And the other point that you made in there that is super important is that some people will probably tend to not bring it up, or definitely not call and make an appointment if the hallucination doesn't like it doesn't seem that big of a deal. Like it just doesn't bother them. They're like, oh, okay, no big deal. So I think that's a really important point to make, that no hallucination is a good hallucination.
Exactly, because it might seem relatively benign to you now, but it is one more thing which can fail quickly. If you fell, broke your bone, had to go into the hospital and you needed anesthesia. Anesthesia is going to not only make you sleepy, but it's now going to provoke your hallucinations.
Yeah.
You had a bronchitis come this winter, COVID, flu, something. Again, what could have been just a cold has now become a bigger problem because it activates your hallucination. Your summer, you decided to work in the backyard, didn't drink enough that day, dehydrate, that day night you start. So there's a lot of unsurety when you have something like this floating around. And we tell folks, look, it is your choice. When it is this mild and non-intrusive, I get it. You don't want to take one more pill in this big med list that you're already on. but understand the risks of doing that over the course of these next several months. So we can either wait and watch and treat it when it gets severe, or we can treat early. But in between, if we wait and watch, understand that you may have these risks. And some people decide to take that risk. It's philosophical choice of taking less meds. Some people understand once they get that part, go, wait, I want to start taking meds early.
Right. Great. So great advice for people. If you're starting to experience any of this, even if you don't think you want to go down the medication route, talk to your doctor about it. Make sure that you're sort of noting it. Maybe your care partner can help you with it, to track these things. So you can talk to your doctor about it next time. You can talk to your doctor about your current medications, and then what you might be able to do to slow this progression or make it not so severe that you get yourself in a bad situation. Thank you so much, Dr. K, for being here today. Like I said, I just want to talk to you forever. It's so helpful. Anybody has any questions, you can always email me at blog@dpf.org. And we will look forward to having you guys back on another webinar very soon. We will send the recording, audio, video, transcripts, all of those things. And thank you so much for being here. And tell your daughter we said congratulations on her fundraising. Very good job. And we will hopefully talk to you very soon, Dr. K.
Thank you, everyone. Stay safe.
Thanks, everybody.